The design of the study, or the intent of the study, was to test whether pulsed field ablation is non-inferior to cryoballoon ablation in patients with paroxysmal atrial fibrillation undergoing pulmonary vein isolation. You know that the field has moved quite a bit in that direction, but the only randomized trial to date that has looked at that patient population was the ADVENT trial. And in ADVENT, the cryoballoon ablation or thermal ablation and pulsed field ablation came out in pair, right? So the things that were special in ADVENT was, first, the operators did not have no prior experience with pulsed field ablation. That was one. And second, the study used intermittent Holter monitoring, and so that's a bit a hit or a miss, right? So you don't capture all the recurrences over time. So the things we wanted to do differently was, first, all operators in the single-shot champion trial did not only have plenty of experience with cryoballoon ablation, but also with pulsed field ablation. And second, we used implantable loop recorders for continuous monitoring so that we got the full picture and a more accurate capture not only of the episodes, but also of atrial fibrillation burden. You asked about the patient demographics and characteristics. Those were very well balanced between the two groups. Patients were about 60 years of age, 30% of the patients were female, CHA2DS2-VASc score was 2, and about 20% of the patients had been treated prior with antiarrhythmic drugs. This was a randomized, controlled, non-inferiority trial that was conducted at 2 centers in Switzerland with a blinded endpoint adjudication by an independent clinical endpoint committee. I think that's very importantly, and also very importantly, loop recorders were used for the endpoint assessment. Patients were randomized in a 1-to-1 fashion to undergo either pulsed field ablation using the FARAPulse pentaspline PFA device or cryoballoon ablation by means of the Medtronic Arctic Front cryoballoon, and then received the implantable loop recorder at the end of the study procedure. And then first primary endpoint was the first recurrence of atrial fibrillation between the days 91 and 365, so with the use of a blanking period of 3 months. So if we start with the procedural characteristics, comparing the two ablation systems, the procedures done with the PFA device were faster. The procedure duration was less than an hour in the PFA group, and it was 73 minutes in the cryoballoon group. This translated also in shorter left atrial dwell times, which is important with regards to cerebral emboli. There was no difference in fluoroscopy time. Then in terms of the safety endpoint, we can say that in both groups complications were rare. And so the composite safety endpoint occurred in 1 patient in the PFA group and in 2 patients in the cryoballoon group, and that was 1 minor stroke in the PFA group and 2 tamponades in the cryoballoon group. With regards to the long-term outcomes, what we could see was that the freedom from recurrence in the PFA group was 62.9% as opposed to 49% in the cryoballoon group. That gave a difference of 13.6%, and this met the criteria for non-inferiority, and even more, subsequent superiority testing indicated that it was even barely statistically significant but superior with a p-value of 0.046. One thing that was striking in this study was the recurrence rate during the blanking period. So that's the first period after the AFib ablation, and usually we see that there's some AFib episodes happening that wane away over time. And what we could see here, that during the blanking period there were significantly more recurrences with cryoballoon. It was in the range of 60% as opposed to 40% with pulsed field ablation. And I think that's a very important finding that we have seen for the first time, that the different mechanisms of cardiac injury during the ablation with the 2 technologies translate in a different pattern of cardiac recovery in the months following ablation. I think that was number 1. And then number 2, even with the use of the blanking period, the treatment effect, the 13% difference between the 2 groups, I was surprised. I wouldn't have expected that to be that large. I think if we are comparing two technologies in a trial, I think that's the way to go for the future, because we capture the full picture. We can have a look at what's happening in the blanking period, what's happening later. We can capture AF burden. So I think that's probably should be the new standard for ablation studies, comparing two different treatment modalities. What we've seen in our trial was, interestingly, that the redo rate was significantly higher compared to the Advent trial that has not used continuous rhythm monitoring. And I think it's probably that several of our patients came back saying, I feel very well, and then in the implantable loop recorder we have seen there's still some episodes left, and going forward they restarted to feel it, and so maybe we did too many ablations. So while for clinical care, probably implantable loop recorders are not all that important. For study purposes, I think it's very important. Even before the results of today, I have to admit that in our daily practice we have pretty much gone away from cryoballoon ablation, and we have moved to pulsed field ablation as our default strategy for a first pulmonary vein isolation. And I think with the data we have right now, I think we have a device that gives you a shorter procedure time, very low complication rate. It gives you significantly fewer episodes of atrial fibrillation during the blanking period, with a reduced AF burden during the blanking period. And then after the blanking period, it was not only non-inferior to cryoballoon, but we also had a lower rate of recurrences. I think that's for sure the day that I personally probably will stop cryoballoon ablations.